I'm director of the Christian Regenhard Center for Emergency Response Studies here at John Jay College of Criminal Justice. And for those of you who are new to our event series, we hold a monthly series of lectures or events during the academic year on various topics related to emergency response, kind of broadly defined. The center is actually named for probationary firefighter Christian Regenhard, who died in the collapse of the 9/11 and the collapse of the World Trade Center. And so I will send out a link to our webpage for those of you who may not have it. Just some housekeeping. This conversation will be recorded, and we'll send a link to the edited video once it's completed, usually within a week or so. And normally we will take all the questions in through the chat feature. And just a reminder, please remain muted and with your video off through the discussion. All right, so with that, I want to introduce today's talk, and it's really a timely topic. We're pleased to have Daniel Gerard, who's currently president of the International Association of EMS Chiefs. Daniel is working with the center on a project that we're completing for the International City County Management Association, the ICMA, looking at emergency response to behavioral health incidents kind of nationally, and trying to discern lessons and kind of strategic areas of focus. And the issue, of course, is a big one that's been getting a lot of attention and continues to. And there is still no real consensus, nor necessarily should there be a consensus on a single ideal model. But different communities are taking different approaches, and there's a lot of work being done in this area. So we're very pleased to have Daniel with us today. And so with that, I will turn it over to Dan. Take it away.
Thank you, Dr. Jennings. It's a pleasure to be here with everyone today. Let me share my screen here and let me see if this comes up. Can everybody see this?
Looks like you got it. Actually, we've got your.
How's that? Is that better?
Yep.
Great.
Yeah, we're good.
So today I'm going to talk about developing a community-based response model for patients in crisis. And a large part of this comes from the work that we did on the ICMA project, but also from my experience operating a community mental health response unit where I'm at in California. I don't know why it's jumping around like this. I have no financial interest in mobile crisis response. And as I stated, my department currently operates a mobile crisis team. I'm not a licensed clinical social worker, but I did get to meet Randolph Mantooth. And I guess you have to be of a particular age to appreciate that. But if you Google Squad 51 in an emergency, you will understand the significance of that statement. This is a short article on developing a mobile crisis response team. I'm the author of it. I published it last year, I believe, through EMS World. But if you're taking notes, if you're looking to gather additional information, this might be something that you could share with other people, and hopefully it will have some good information for you in there. I need to provide a warning to you. I have 1 or 2 video clips in here that show encounters with patients that are in crisis that unfortunately resulted in their death. And it is a violent death. And so I'm giving you this warning now, and I will also give you a heads up warning again before we play the video. So if this is of a concern for you, you may either avert your eyes or turn the volume off on your computer, or you may log off at that point. So as Dr. Jennings pointed out, I'm an EMS coordinator for a fire department in Northern California. I'm the president of the International Association of EMS Chiefs. I'm a former professor in the EMS degree program at George Washington University. And currently, I'm a doctoral student in organizational leadership and health policy. But in case you didn't guess, I'm not originally from California. I'm a Jersey guy, born and raised. I spent 20 years as an EMT and paramedic in Newark, New Jersey. I cut my teeth on the volunteer first aid squad, and I had the opportunity to work around the world. I did the EMS system redesign in Hong Kong. I worked for Chrome Monsell at the time. I did a little bit of work with the Pan American Health Organization, and I got to co-author a book with them, Emergency Medical Services, Lessons Learned from the United States of America. And I worked in the Bahamas, which was extremely difficult. And I've because we went to lunch every day at 12 and essentially didn't go back to work. And I've worked with various members of the federal government on both sides of the aisle. A lot of people ask me why I left New Jersey to go to California. This is not the reason why. And I want to kind of plant this seed in everybody's head. I think a lot of times we talk about alternative response and we use the term alternative response, but realistically, I think that we should be talking about appropriate response. And I think that when we use the term alternative, for some people, it's almost as if it's lesser than. And really, if we start thinking about appropriate response, then we think about it as an equal in our space. So before, we used to think of 911 as police, fire, and EMS. Now we need to think about it, police, fire, EMS, behavioral health response. And they also have their own number. They have 988 too, but we'll talk about that in a little bit. Why the big push for us to speak and work with patients with mental health disorders? The ball was kind of put into play over 30 years ago and was recognized by the World Health Organization that we were going to see a tremendous rise in mental health disorders across the globe. And when we look at the numbers, it really becomes overwhelming when we think about it. Before, we sort of captured health and mental health, and we thought about them as two different entities. And really, mental health is health, and we need to approach it from that standpoint. Our biggest challenges are not only the people that we encounter every day who have mental health disorders, but also people that we have a tendency to warehouse. And when I talk about warehouse, I'm talking about individuals that are incarcerated, where the access to services and care isn't equal to what they have on the outside. And then individuals that are, I want to say, undomiciled, don't have the same access to care. And so, as crazy as this sort of sounds, we sort of warehouse undomiciled people on the outside of the healthcare system, and they don't have the same level of access, and then we don't get the opportunity to interact with them until they're absolutely in crisis. But this issue and this problem has accelerated because of COVID. COVID, when we started bringing people inside and we started isolating them from other individuals, it created an incubator effect that in essence made the signs and symptoms of mental health conditions and problems more prominent. It made them more visible. It accelerated the problems that we were viewing in the community and in society as a whole. So the first thing I would ask you is, how many people in your community require behavioral health or crisis services? And, we've never had a really good number or a really good handle on that. In major cities, when we talk about cities like New York or Houston or Los Angeles, we have a better idea than we do in smaller communities. But realistically, a lot of this has to do with response models and how we report information back and how we gather information. How do we plan to respond to these types of events? Sometimes it's after a very tragic event unfolds. So somebody dies as a result of a poor response. And now we have to re-envision ourselves, what we're going to do, how we're going to respond in the future. And this is really sad when you think about it, because, someone had to die or suffer needlessly in order for a change to happen. And in some places, it's part of an ongoing process of evaluation. So when we look at places like Chicago, Atlanta, Los Angeles, San Francisco, New York City to a degree, this is part of an ongoing process of evaluating what they do in the community, reevaluating it, coming up with new plans, coming up with new approaches, and working on it. I would say that places like Los Angeles and San Francisco have been working the system and trying to develop a system for a longer period of time. But I also don't want to leave out our friends from Chicago and Atlanta as well, because they've been doing some tremendous work as well. Here, let me. So how do you currently provide service? One of the things we found out is that sometimes this is based in a single agency. It may reside within the police department. As a matter of fact, and I'll get into this in a little bit more detail, and a lot of organizations in a lot of places, this was primarily a police response for time immemorial. Some organizations, some cities provide it as a contracted service, and they will partner generally with a nonprofit or maybe a healthcare system, and they will have a mobile team that will go out and work with individuals. In some organizations, it's part of an interdisciplinary team. So, and they call this a co-responder model. So you might have EMS, police, and some type of social work team responding to this. And unfortunately, in some locales, it's whoever is available. So if we have a police car to respond, we're going to send a police car. If the police aren't available, we'll send EMS. But, we'll get somebody out there. It's in the queue, and we're going to respond to this as soon as we can. So why mental health? Mental health. I'm sorry. I don't know why I did that. Mental health has significant impacts not only on the psyche of the individual, but also on their physical health overall. Crisis response in many locales for decades was primarily a law enforcement responsibility. And the police assumed that mantle for a variety of different reasons. If you go back in history and we look at this, we will see places like Chicago, New York, LA, where they have looked at they had a social worker before that would go out into the community and work with members of the community. And over a period of time, that kind of got to be too expensive. And so instead of sending a team of social workers out into every community, they would have the social workers based at a hospital or some other government facility. And then they kind of transitioned it over to the police because the police were the boots on the ground. They were patrolling every day. And I'm talking about in a lot of locales, I don't mean to use cops, but law enforcement, were primarily on foot beats. And everybody in the neighborhood knew the local police officer, and they kind of had their pulse on the community over a period of time. And to a certain extent, this probably made sense, but we really needed the psychiatric social worker. We needed the social worker as part of that. And then over a period of time, there was this change in the social and political construct and negative interactions between police and the people that they were trying to assist. Many of these have come to the fore over a period of time because of body cam footage, because of cell phone footage, and it has given us a greater opportunity to see what we're doing, why it isn't working, and what we need to do better. And this has gained increased emphasis over the last 10 years because as the rise of mental health disorders has occurred and as it's become more prominent, coupled with the fact that we have more a video documentary of what is happening in the community, it has made many of us turn around and say there has to be a better way. So many communities across the United States look to transition from a police response to an appropriate response model. Some places are still going to call it alternative response. And I feel like Don Quixote here. I'm tilting at windmills when I say this, but they've transitioned from police response to an appropriate response model or a co-responder model. And places like Cahoots in Oregon, I don't want to say that they were one of the first, but I think they were one of the first to gain national attention with their change from a police model to one where they have peer support specialists and paramedics and EMTs to go out and work with individuals. There's a lot of energy right now for organizations to go with the co-responder model, where they have some type of EMS presence, where it's an EMT or paramedic. They have a police officer, and they have a licensed clinical social worker, or maybe a behavioral health technician, or a peer support specialist, and they respond out as a team. The police officer dresses down. He's probably wearing khakis and a golf shirt. If he's carrying a weapon, it is not visible. And then some places have contracted wholly out to outside agencies. These non-governmental organizations that work in the behavioral health space, and they have no law enforcement response whatsoever. So When we have this co-responder model and we have these outside contracted services, generally what we're seeing is that we're only sending them to these non-violent patients or these non-violent responses. And at the same time, we're also providing them with de-escalation training, which is essential. And I'm going to talk at length about the training component in a little bit. But we're trying to, realizing that these are people that are in soft clothes. We want them to be actively engaged in the community. At the same time, we don't want to put them in harm's way. Now, sometimes when they're dealing with people that are in crisis, they need that de-escalation training to lower the temperature and try to bring the client that they're dealing with more in line in order to be able to assist them. And so for these co-responder models, we see a variety of different structures to them. And so, I'm a paramedic and a registered nurse. And so, you might see, a registered nurse that's part of the team, and some organizations have that. Some organizations have some form of EMS provider, whether it's an EMT or a paramedic, a law enforcement officer, and a licensed clinical social worker, or a peer support specialist and a licensed clinical social worker, or behavioral health technician and a licensed clinical social worker. Some organizations, there are some EMS models where they have an EMT and a paramedic, and they leverage a telehealth model in order to contact their licensed clinical social worker or their behavioral health specialist. And they'll get the they're using something akin to FirstNet that's HIPAA compliant. They'll get their provider on the phone, and they'll hold the phone up, and they'll interact with the patient that way. Or they may just do a phone consult where they either discuss the case with the behavioral health specialist or they pop the patient on the phone. But there are as many different cities as there are in the United States. There's probably as many different, well, that's getting a little crazy, but as many different communities, there's as many different service delivery models. A lot of this has to do with capabilities and capacities within the communities that we're talking about. And for me, I'm in a primarily urban area. And so you would think that it was easy for me to access behavioral health personnel to roster out on our crisis mobile team. But actually, we use a telehealth option because our call volume isn't at the point where we could support someone full time. In rural areas in the United States, in frontier areas of the United States, telehealth may be the only option, again, because of the paucity of calls, the distance between patients and interactions. And again, it just may not be able to support that licensed clinical social worker. But you have a variety of different configurations that can take place, and it doesn't the telehealth option or any other option isn't necessarily a geographical issue. It just might be a personnel issue. One of the things that I want to point out is that for the mobile crisis response, one of the things that we learned right away was time on task. So, I cut my teeth in this business in EMS, and over a period of time, you kind of figure out, hey, listen, we're going to this patient's house. They have asthma. We've been there before. This is like a 20-minute call. We're going to be on scene 20 minutes. We're going to get a set of vital signs. We're going to give the patient albuterol treatment. Maybe we're going to start an IV and give them some Solumedrol, pop them in the chair, bring them down the stairs, reassess them, give them another nebulized treatment, and away we go. And it's the same thing with chest pain patients. When we moved into the mobile crisis realm, the EMTs and paramedics realized right away that the shortest amount of time that they were going to spend on scene with somebody was probably about 45 minutes to an hour. You know, average time on task with some of these patients is about 2 hours. We've gone 6 or 7 hours on scene with one patient. The other issue, that you have to sort of figure out is transport. If you have a client that you encounter and you need to bring them into a behavioral health facility, or that you need to bring them in to see a counselor on an outpatient basis, how are you going to get the patient there? We could call the 911 ambulance, but realistically we only call the 911 ambulance if the patient has to be restrained, because with restraints, there's a greater chance that there's going to be a negative outcome. Patients could go into respiratory or cardiac arrest. So, that would be the only time we would call a 911 ambulance. The rest of the time, we either use a non-emergency ambulance provider or we transport the patient in our vehicle. And that's the model that a lot of organizations take. They have a vehicle that has some type of transport capability, and it doesn't have to be anything special or crazy. It could just be a simple van. We use an SUV, and we have a designated patient area, and we have a cage between the driver and the I shouldn't say cage, I'm sorry. We have a barrier between the driver and the backseat passenger. In regards to equipment that the care team needs, a lot of places, have run a whole host of equipment. I would say that at the bare minimum, you sort of want, you want a first aid kit and you want an AED in case something goes wrong and the patient goes into cardiac arrest while you're restraining them, if you have to restrain them. There might be other substances that are involved. You might arrive on scene and you might find that the patient's been using opioids and they're overdosed. So having the capability to administer Narcan. Sometimes patients may have attempted suicide, and they'll have, they may have attempted to cut their wrists, and you need to provide some type of basic care. Some organizations do like a full ALS kit and cardiac monitor and the whole 9 yards. Again, a lot of this is based on community need and community response, but some of it can be overkill too at the same time. Police response can become uneven. Now, what do I mean when I say that? Well, depending on the officer, their experience dealing with patients that are having a crisis or that are having a behavioral health issue, if they're new and they don't have a lot of experience, their interaction with the patient may be different than an officer that has years on the job and who has considerable experience in dealing with clients in this realm. Some organizations, like when you talk about Seattle Police, they have specially designated officers. That's their job. They have additional training. They have enhanced training and education in order to work with these members of the community. But in some locales, it's whichever radio car is available. And again, it might just boil down to like, this call is in your district and you're going on this call. And the training and education that you have may be the bare minimum, either what's offered in the police academy or as part of your onboarding process. But you really don't have the ability to develop increased competencies over a period of time. The crisis mobile response interaction is just, in your organization, is just another call with car break-in, parking enforcement, etc. So, this is just one of the things, and it's not a complaint against police departments, but I think that one of the things that you need to consider is, some of this boils down to budgets, personnel, etc. Before this, I'm going to play a video that is going to show a police interaction. And unfortunately, in this interaction, the individual dies. So this is Patrick Warren. This is from Texas. I'm going to give you the opportunity now. You can stop the video, mute the screen. But I'm giving you fair warning now. So this is Patrick Warren, and this is from Texas.
Police. Is the door open? Hello. Hey. Okay. Come on in. Come on in. Okay. Hold on, man. Let me. No. Come on. Okay. Come on in. No. I'm gonna walk back out. I don't work like this. Hey. Give me the channel. I had to come outside. There's about 6 of them in there. He came rushing at the door. He closed the door on me, so I'm just waiting for more units. Let me see your hands. Let me see your hands. I want to change the point. Let me see your hands. Get down on the ground. 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 You're gonna get tased. You're gonna get tased. One tase. Lay down on your back. Lay down on the back. Lay back. I'm gonna shoot you. I'm gonna shoot you. Police.
I wanted to stop this before he actually discharged his weapon. I could tell you that if we played it all the way to the end, just the emotional response to the office by the officer is really heart-wrenching. Just to hear his emotions at the end. This incident unfolded fairly quickly. The officer, and this is not a comment for or against the Killeen Police Department. Please do not misinterpret anything that I'm saying to be a comment about how they should have done, how they should have managed this response, or how this response could have been managed better. But what I will say is that you notice that the incident unfolded quite rapidly. The officer made entrance into the home. There were several individuals that were in the home. I don't think we saw everybody that was in there. I don't think the body cam gave us that visual. But there was the individual there that he was assigned to, that, he needed to, that he was supposed to um, uh, find out what the issue was and what the problem was. And then, he exited the building, to a safe place. He called for backup. You could hear the sirens in the background. People were coming to his assistance. And, he backed up and he tried to create distance and space between him and Mr. Warren. He attempted to use non-lethal force. And then, unfortunately, he had to resort to lethal force. And again, I kind of stopped it right at the, right where he discharged his weapon. But it was a couple of seconds later. It wasn't, it was an incredibly long period of time. I mean, that incident was like a few minutes, but it rapidly evolved to a point where it resulted in the death of Mr. Warren. The Substance Abuse and Mental Services Health and Mental Health Services Administration, SAMHSA, is an administration within Health and Human Services, and they've developed national guidelines for behavioral health and crisis care. They've essentially developed the best practice toolkit. And what I want to point out to everybody here is that what they have put together is really the essence of a system of care. If we look back at EMS evolved from a white paper that was written by the National Academy of Sciences back in 1966. And it sort of outlined this same sort of system of care, a single resource number that people would call, specially trained EMTs and paramedics that would respond to the scene, and then trauma centers. It was essentially focused on trauma care and, in particular, motor vehicle accidents. I think that out of the entire paper, 1 page was devoted to EMS, and it was only 33 pages in length, but 1 page was devoted to EMS, and it sort of kind of gave this outline of a system of care. This is what SAMHSA and their best practices toolkit has kind of come up with. So a regional crisis call center, we've seen the 988 number, or we should have seen the 988 number on billboards. We should have heard radio announcements or something on Twitter or X, whatever we're calling it this week, Instagram. And the regional crisis call center first is meant to de-escalate patients that are in crisis over the phone and get them the resources and the services they need if they're contemplating suicide. And they really haven't formalized it yet, but it's also the ability to send a crisis mobile team out. We have been having discussions about this in the, I sit on the co-responder consortium, and I work with some of the people at NHTSA EMS office. And it's, what's this interaction between 988, 911, and dispatch of crisis mobile response teams? The crisis mobile response teams is exactly what it is. They are teams specially trained to work with patients that are having a behavioral health emergency, that are in crisis, that are in harm's way or presenting harm. And it's meant to de-escalate situations, get patients the care and services that they require. And then the crisis receiving and stabilization facilities think about it, are the trauma centers for mental and behavioral health. They're the facilities that we ultimately want to bring patients to. Now, realistically, patients that enter 988 through the regional crisis call center and or have access to or encounter a crisis mobile team, those services have the capability and capacity actually to divert patients from having to be have their rights taken away and be committed. What they're really trying to do is get patients the appropriate services that they need, not to end up in a waiting room for hours on end, or not to be taken to a mental health facility and be locked down for 72 hours. But, try to match patients up with counselors or services that they require. In the co-responder model, the reason why the co-responder model works the way that it does is that what we've come to find out over a period of time is that individuals that appear to be in crisis or that are actually in crisis, a lot of their issues and problems stem from very basic sort of interventions. They need housing. They require medications. They're looking for food. Okay. They are having issues at home with family members who don't understand their mental health condition, or with other individuals that they're affiliated with. They may be undomiciled. The group of people that they are staying with or encountering day to day don't understand this individual's mental health problems, and they may play on that to a certain extent. Some of these individuals have substance use issues, and they need detox and rehab, and they need other care. So in the co-responder model, by having police, EMS, and some type of having some type of mental health specialist who can provide care for these clients that are in need, we can address all these issues. Oh, you can't get your high blood pressure medication. Let's work on that. This individual is bothering you. Let's work out a safety plan, and the police will interact with that individual, and they will become the barrier between you and them. You feel very vulnerable. You don't care anymore. You want to hurt yourself. Here, let's work through this issue. Let's work through this problem, and let's get you to a good spot and get you the care that's appropriate for what you need. Putting together one of these teams can't be approached from a knee-jerk sort of reaction. And I would caution anybody to think that they could copy and paste something that was going on in the next community and implement it successfully in their community. I think that you really need to, take a public health approach to this and use all the tools that are available to you. So the first thing is to do the needs analysis that's essential to providing any type of service in the community, health, behavioral health, whatever the issue is, and find out, what are the problems that you're encountering, how many clients are we roughly talking about? What are the capabilities and capacities in the community to manage this? You could put together the best plan in the world, but if you don't have a receiving facility when you have patients that are in crisis, where does that patient going to end up? I mean, they're going to end up in the emergency department at your local hospital. How is that going to work? We need to work out a better plan with the hospital that's going to receive that individual. If you don't have mental health resources that are available to you in your community, what's the telehealth option, and who's going to want to enter that space? You have to remember that some of the individual organizations that are going to step up and look to help you may not necessarily, they may have experience working with people with mental health and behavioral health issues, but they may not necessarily have experience working in crisis response and or providing street side care. So this is a balancing act here. And so selection of who we're going to use and how we're going to employ them is critically important. Do they have the reserve, their own mental health reserve in order to deal with patients in crisis? Remember what I said before. Sometimes we're on scene with clients, for 45 minutes to an hour. Sometimes on average it's 2 hours, and some clients it's up to 6 hours. So do they have the capabilities and capacities within themselves to do that? A lot of people so not every EMT or paramedic could kind of step into this space. A lot of people that come into this, they sort of like that instant gratification, that they get from treating an asthma or taking care of a patient that is having a diabetic emergency, because they get to see that. They get to experience that real time. With some of the, with a majority of the clients that you're going to deal with, you may be dealing with them for years. And not that they're in crisis for years, but you're going to kind of come to figure out over a period of time that they're really not in crisis, but they need more social work issues than they do mental health issues, and it's transitioning them over to someone that's more appropriate to provide the care that they receive. Resilience is critically important for your entire team. We've done a poor job of this for police, fire, and EMS in order to manage their mental health. But now it sort of becomes amplified when we pop them into this co-responder model. Training, we're going to get into training a little bit, but training has to be specific to what they need. And again, I'm going to go into a deeper dive into that. Finance, who's going to pay for this? When they first started paramedics in the state of California, they were the Board of Supervisors in LA County were, they just kind of funded it for a year as a pilot program. And then it was only after they made an impassioned plea later on, when they wanted to sunset the program, that Jim Page and the other pioneers in the field in LA County were able to convince them that this is worthwhile and you need to continue to pay for that. That really pointed out to like a simpler time in the history of the United States where people just did stuff because it was the right thing to do. Now the first question everybody asks is, this is a great program, how are we going to pay for it? And then finally, calls and outcomes. How do we discuss successes and challenges? So let's talk about some of the lessons learned. The community assessment, the needs analysis is crucial to the success of any program. And it's not only the number of patients that you have to manage. I mean, what if you found out you only had like a handful of patients every month? It doesn't mean that you're not going to provide care for them, but you might look to do it as part of a regional resource than an individual city resource. If you didn't have social workers that wanted to come into the system, This could be a bigger issue overall, because social workers do a couple of different things. One is that they're providing and licensed clinical social workers, mental health specialists. They're not only providing direct care for the patients, but they're also monitoring the temperature of your team. They're helping to monitor their mental health as well. And in paramedic education, I think let's talk a little bit about that. When we look at the typical EMT or paramedic, they only get a couple of hours of classroom instruction. If you're an EMT or paramedic, that you get hours and hours and hours of classroom time and lab time and ride-along time where you're taking care of cardiac patients and trauma patients. Those are the two big categories of patients that we take care of. But when we talk about behavioral health emergencies, I mean, for EMTs, it's 15 to 20 pages. For paramedics, it's 20 to 30 pages. A couple of hours of classroom instruction on this, and then you're done. We don't provide any type of clinical or practicum experience out into the field. New Jersey does an interesting thing. They send patients they send paramedics that are in the paramedic program for 12 hours of observation time in a psychiatric unit. But, you're really not observing clients in crisis at that point. You're observing clients that are receiving therapy, they're on medications. You might have somebody that's restrained in there, but realistically, you're not seeing the types of clients that you would encounter that are in crisis. Conversely, let's look at the licensed clinical social worker. They get 6 to 7 years of education, a bachelor's and a master's degree. They get clinical rotations, on top of which they get a whole host of training that's relevant to their mental health resilience and how to protect their mental health. And the same thing goes for psychologists and psychiatrists, right? So psychiatrists, they do an internship after they do like their they do like this they do like 1 to 2 years of like this general internship where they take care of patients and they get the basics down of being a doctor. But then they'll go into a psychiatric internship that could be like 3 to 4 years. All right, and then they'll sit for their certification exam. Psychologists, they're getting their PhD in psychology, on top of which, psychologists and psychiatrists actually go to therapy as part of their educational process to see how well that they're working and dealing with individuals. We don't do that with EMTs and paramedics. So a lot of this, when we select our teams and we compile our teams together, what is the resilience training what is the resilience protections that we put in place for them as part of their training, as part of their education, as they move forward, through the program? Do we need to have them? Is it a good idea to have an EMT, a paramedic, and a police officer, or even a licensed clinical social worker on the unit for 5 years or 10 years? I'll tell you an interesting thing. I thought there was a period of time I thought I was going to get out of EMS, and I became an investigator for the medical examiner's office. And the first, after I was trained, the first response I went on was the Unabomber case, and it was Mosier in West Caldwell, New Jersey, and I met the guys from the behavioral health unit from the FBI. We were like this. We were this multidisciplinary team. There was somebody from the prosecutor's office, somebody from the state police. There was me, the FBI guys, and people from the Postal Service. And talking to the guys from the behavioral health unit, I asked them, I was like, oh, wow, this is great. This must be like really interesting, et cetera, et cetera. And the guy told me, he says, yeah, he says it's like a 3-year rotation. And then you come out and then you could come back in for another 3 years and that's it. And I asked him, wow, uh, that's interesting. Why do they do that? And he said, because of the extreme mental and emotional burden that we assume by working these cases. We can't be in this spot for too long. It would damage us too much. And maybe this is part of the um, process, or maybe this should become part of the process for our teams, how we select people and how we put people into these spots. He said that this wasn't only limited to the behavioral health unit. This was also individuals that worked on sex crimes were only in there for, they did like a 3-year rotation, then they would come back and then they could come back in again. And then the only way you went back to behavioral health unit was you would go in in a supervisory role, but you weren't working cases day to day. And again, that was a limited time frame assignment. So when we talk about resilience for our providers, and especially in a co-responder model, the mental health specialists that we pick to be part of the team are better prepared for this. But for the police officers, for the EMTs, the paramedics, the firefighters, whoever we're putting into this role as part of the team, maybe we should also consider the fact that we need to limit the amount of time that they spend performing this job. One of the things that we learned was that a lot of the training that was provided was originally developed for licensed clinical social workers. And this was developed specifically for them. So realistically, it didn't address the gap in education that EMTs, paramedics, and police officers had. And so while this training was very informative, some of it was over their heads, and some of it, there was such a big gap between what was provided and what they were expected to know as a baseline, that it was difficult for them to bridge. And so, we started to parse down into this. And I mean, this is just generalized outline. This is not a curriculum by any stretch of the imagination, but it is a whole host of issues that you may encounter at different times. People with postpartum depression, post-traumatic stress disorder, individuals that are suicidal, that are homicidal, that have that are bipolar. There's so many different issues that we touch on. How do we deal with clients that are deaf? There's a variety of different issues that are there. How do we deal with patients that have dementia? One of the cases that we worked on that came in as a behavioral health issue was a law enforcement officer with early onset dementia. And he was 62. And he was walking around and he was punching people in the face. And so that in and of itself is a problem. But the other side of the coin was he also used to be the boxing instructor at the police academy. So when he punched somebody in the face, they knew it. And so, how people interacted with him, originally this came in as a, behavioral health issue, but then, then we figured it out that he had dementia, and we were able to manage the call after that. We had somebody come from the county sheriff's department where he used to work, And once he didn't recognize the person, but once he recognized the uniform, it gave us a spot to work at with them. Crisis care has a variety of different factors, de-escalation techniques, provider protection, protect and evade, what we're going to do if we encounter somebody and we can't de-escalate the situation, or and we've seen this happen a couple of different times. Sometimes calls come in to either 911 or 988, and the client is calm, but they are having a behavioral health issue. And in between the time the unit is dispatched and the time they arrive on the scene, other individuals at the scene have escalated the patient to a certain point. And now when the team arrives on scene, they have to de-escalate the patient. And in some cases, they have to protect themselves and evade and leave the scene. Restraints are not totally out of the equation here, and that's either physical or chemical restraints. And then documentation, clinical practicum, this is all part of the education process. Police officers, it is critically important that they have training, and more than like this check the box 40 hours sort of training if they're going to be part of the crisis mobile response team, but also generalized training. Like every officer needs training, because think about it, you may have an individual that has a behavioral health issue, but they're calling because somebody broke into their car. And so now, depending on the interaction between that individual and the officer, once they arrive on scene, if the officer doesn't have any training, you could see how it can escalate if he can't recognize that this person has a behavioral health issue, in addition to the fact that somebody broke into their car. And there are a variety of different responses that police officers have to respond to. So, police officers that are part of a crisis mobile team need they need to be trained very well in order to interact and function as part of that team. And then officers who are not part of the team need training, because patients with behavioral health and mental health issues call the police for things that are not related to that, but that may be a trigger point for them to have an issue when the officer arrives on the scene. In addition to, we want those officers trained well, because if they encounter the crisis mobile response team, if they have better training and a better understanding, they'll be able to operate in a more efficient and more effective manner with everyone that's on scene. There's a few different things that need to go on. There's the dispatch to the scene. Who's doing that? Is it 911 or is it 988? It's the scene size up, right? So, some of the first things we're trying to do is identify routes of egress. What are the danger signs? We had an incident not too long ago where a guy was running around with a samurai sword. That was sort of easy to figure out that was a danger sign. But, some things, might seem innocuous. We had an incident not too long ago where an individual had his backpack and he had a handgun in there. So, recognizing, danger and potential things for danger, and then obviously de-escalation, protect, evade, and escape, and then restraint, chemical restraint, and physical restraint. Our assessment is very basic on the EMS side. We don't go in there and take a lot of vital signs. Essentially, we go off of mental status. So, we look at, is the patient alert and oriented ×3, and a lot of people mistake that for decision-making capacity. That is in no way indicative of decision-making capacity. That has to show that the patient is oxygenating and perfusing their brain well. And then we talk about decision-making capacity, and we talk we talk, and that's an interactive, interrogative approach, determining whether the patient has decision-making capacity, questioning the patient, do you understand what's going to happen, etc., and having the patient explain it in their own words, not yes or no answers, but being able to explain it. And then skin signs, obviously, if somebody is pale and moist, that might point to like a perfusion issue. It might even point to some type of substance use issue. And then everything else is based on, do we have a need to do a physical exam? Does the patient have a history of diabetes? Maybe he might be hypoglycemic. If his SpO2 is 76, he might be in the state that he is because he's hypoxic. So, everything else kind of unfolds after that. Dispatch operations, we try to figure out, is there a history of violence, or is there active violence being reported from the scene? So, if somebody's running around with a baseball bat smashing windows, or if the client has a history of violence with first responders or mental health professionals, we might defer response and let it go to law enforcement, or respond with a larger law enforcement presence, and then try to mitigate it while we're on scene with law enforcement providing protection, or trying to manage it interactively with the police, trying for the best outcome possible. And a lot of this goes back to training, working with law enforcement, not only on scene, but scenario-based training opportunities where we could kind of work through issues and problems ahead of time. When we see red flags, we want to leave the scene immediately. And some of those things may not necessarily be specific to that patient. If you have somebody that's undomiciled and they're in an encampment of other individuals, it may not be safe, not because of the individual, but because of the other people that are on the scene. So, these are all things that we need to take into account. Some providers wear stab protected vests that will provide protection from penetrating wounds or from gunshots. This is an entire process that we wrap ourselves around. Some people feel that wearing the vest provides a barrier, or it changes the tone or tenor. I would say that wearing enhanced protection capability is dependent on your needs analysis, the clients that you're encountering, and issues that you've had with violence against providers in the past. If you look on that cabinet, that one vest up on top there, it actually has a panic button that goes like right to the police department. And many of these teams, if they don't have a police officer embedded, they have a police radio. And then some teams are actually providing self-defense training, limited self-defense training. I mean, that's the last thing you want to do, is really go toe-to-toe with a patient. You really want to try to de-escalate the situation. If need be, protect, evade, and escape if they come at you. And then the last thing is self-defense if you have no other choice. But this is a really small number of patients that we encounter at this point. When we talk about restraint, it's who, when, why. Medical restraint is different than law enforcement restraint. Anytime a patient has a history of drug or alcohol use, it increases the chance that the patient is going to have a negative outcome and go into cardiac arrest. Whether it's physical or chemical restraint, if the patient has been using drugs or alcohol, then physical or chemical restraint should be avoided, unless there's no other option. And again, it's a roll of the dice at that point. When we talk about law enforcement restraint, you have to remember that a police officer, when they're looking to restrain somebody, they're trying to temporarily limit the freedom of that person. And especially if they're being uncooperative. It's, you're coming into custody, we're going to place you in restraints, you're going to go into the back of the radio car, and then when we arrive at the facility, we are, you're going to go into protective custody, either into a cell or some other situation like that. On the other side of the coin, medical or behavioral restraint, right, is different in that we do this because we want to prevent patients from hurting themselves. If you're an EMS, anytime you carry a patient, you restrain the patient, right? You put you put straps on them to hold them into the stretcher or into the stair chair, to hold them into the cot. These are the things that you do in order to keep them safe. If they're having a mental health crisis, right, we do this to prevent them from injuring themselves or other individuals. So we restrain people, all the time. When we have patients with dementia, we may restrain them in order to perform a procedure on them, to start an IV, etc. I've cardioverted patients and I've restrained them because they have a tendency to try to reach up with their hands and grab you at the same time you're cardioverting them. And that's not like a good thing, to get shocked at the same time that the patient is getting shocked. Sedation. Some clients may need to be sedated, and this is when de-escalation techniques are not amenable to this individual. We have a couple of different substances at our disposal. One is ketamine, which has become very controversial for a variety of different reasons. Elijah McClain was a young man who had he had Asperger's, and he was stopped by the police, but he became agitated because he didn't understand why he was being detained. And so when the police called for the paramedics, they wanted him chemically restrained. And chemical restraint is not a law enforcement function, it is a medical function. And the paramedics not only chemically restrained him at the behest of the police department, but they also used an inappropriate dose. So, there's like a malpractice component that goes with this. Currently, these two paramedics are being charged with homicide. I do not have all the details of the case surrounding Elijah McClain, but I've seen the video several times. It is quite disturbing and is quite upsetting that this poor young man passed away. But again, chemical restraint is a medical procedure. It is not a law enforcement procedure. And if anything, they probably should have made contact with their base hospital. San Francisco Fire Department has sedated 4,000 people in less than 5 years. This was extremely disturbing to me when I first heard this, because first of all, the medication that they use is a controlled substance, and thank you very much for that. Somebody told me that Asperger's is not considered a diagnosis any longer. It's an outdated phrase that the autistic community is against. It's autism. Thank you very much. I appreciate that. Um, uh, the San Francisco Fire Department is being sued currently because of an incident at after a Warriors game where they sedated a woman who they said was that was in crisis. And from bystanders and from the woman's own description, she wasn't in crisis. She was upset, and the exact nature of her being upset is hard to sort of was difficult for me to discern. But hearing the description from bystanders and from the patient that she needed to be sedated, I I don't know. I don't know. I don't think that she did. But again, this is anecdotal. This has been related to me anecdotally. But 4,000 people in less than 5 years, in less than 5 years, to me seems like an extremely high number. Because in my program, we've been operating at 2 years. Now, we haven't treated 4,000 people, but we haven't sedated anybody. And the number of individuals who we've had to put a 5150 hold on, where we take, and a 5150 hold in the state of California means is that you are a danger to yourself, you're a danger to others, or you don't have the means or capability to protect yourself. And then for 70, we could place a 5150 hold where we would take you to a facility and they hold you for 72 hours. And then at that point, at the end of 72 hours, they could go before the court and extend it for a longer period of time. There have been cases where people have gotten a 5150 hold and they were released after 2 hours, where they were deemed to be safe after they were evaluated by a psychiatric professional. But to get back to what I was saying, we haven't sedated anybody in the 2 years that we've operated the program, and we cut the number of patients we put on a 5150 hold before our program was operated by the police department. And now our program is operated by the fire department with EMTs, paramedics, and a telehealth option. And we've cut the 5150 holds down by 70%. So, when I hear you sedated 4,000 people in 5 years, it gives me pause. And, that should be under review by the EMS agency and by the medical director. There's a couple of different medications that can be used for sedation and chemical restraint. Patients that are having paranoid thoughts, etc. We can give them olanzapine, and essentially, it's a little foil film. You hand it to them, and they could pop it in their mouth, and it just dissolves under their tongue. We have ketamine, but we can't use it for chemical restraint. But other organizations do use it for chemical restraint. The medication that we use for chemical restraint is midazolam. But generally, these are the medications that you see being used in the pre-hospital care environment. The last couple of things I want to talk about here is, number one is success. What does program success look like? It has to be well quantified. And for us, when we first started the program, we wanted to reduce the number of clients that were going to be restrained, and we wanted to reduce the number of clients that were getting a 5150 hold. Talking to other places across the country, I was talking to some officers in Texas, and I'm not going to name the city that they're from, but they related to me that they would have to take care of behavioral health emergencies just as if they would if they had a car break-in, etc. They didn't have a specialized officer that was dedicated to that. And one of the problems that they had was that calls would back up in their area, and they were under a lot of pressure to clear calls. So if they couldn't get resolution within a short period of time, they would put patients on a psychiatric hold. And that was the only reason that they did it. And we see the same thing in California and other in other locations where police officers have that capability. It's that calls are backing up. I can't get resolution to this, so I'm going to put the patient on a psychiatric hold, and now it's the hospital's problem, and they have more time to deal with it. So, one of our things that we looked to do was that we wanted to reduce the number of holds that we put on patients and get them appropriate care. That was one of our measures. And then the other measure was we're looking at repeat clients. How many clients do we have that are repeats, that are not necessarily in crisis, but now, need to be transitioned to other care providers within the healthcare system. It's really important to have definitions for your program, both for operational sort of issues. So we have like a whole host of definitions for formerly incarcerated individuals who have a history of violence, undomiciled individuals. We have a whole host of definitions that we look at. The operational issues and operational definitions, previous history of violence on scene, previous history of violence by other individuals on scene, not necessarily the client. So, we have a whole host of definitions that we sort of work through. What are the resources? And the resources are not only the crisis receiving facilities that you may transport patients to. But, we have behavioral health counseling that we get clients into, and they may not be able to get in instantly. They may not, we may not be able to take them directly to the scene, but from the scene, they might have to wait like an hour or two till they can go see a counselor. If we don't take them, sometimes we'll go back and take them. But if we don't take them, how are we going to get them there? What's the Uber resource? When a client needs medications, we had a lady she didn't necessarily need medications for her mental health issues. She had that. She didn't have her blood pressure medication. And she was really worried and she was really concerned. And so what were like the 24-hour pharmacies that were open on Christmas, literally, so what are the resources that we have? What are the resources that you need in order to be a success? And in some locales, it might be easier to put these together than others. But you need a list. You need to put that together. Who are the stakeholders? So it is not only the hospitals and the emergency departments and the police and EMS and the behavioral health it's the behavioral health institutions, it's the schools. A third of all our patients are children under 18. And a third of our responses occur at schools. That may not occur to you, but they're a valuable stakeholder in this entire proposition. And then don't forget the patients. Make sure that they have a voice in your processes, in the services that you're providing, and then trying to define what your outcomes are. Your outcomes may become more granular as you move forward. The two most important things: mental health resilience protection for all your providers on your team, and also a mental health resilience officer. New Jersey actually passed the state law that every police department has to have a mental health resilience officer, and then they have a chief mental health resilience officer in the office of the Attorney General. And so, I think that every agency, even if you're not doing crisis mobile response, if you're an EMS agency, if you're a fire agency, every police department, they need a mental health resilience officer. And especially if you're operating a community paramedic program or a crisis mobile team, you need to have a mental health resilience officer as well. So I think. So our challenges for the future are the systems of care, building them out, especially in rural and suburban and rural and frontier areas. Training, going from competence to competency, because as time goes on, we want our providers to be better at providing care. And then the interface between 988 and 911. Some calls may end up at 988 and may be a 911 phone call. Some phone calls may be a 911 phone call and end up at 988. So how that works. I just have like a little bit of stuff here from LA County, but I'm just going to kind of go through this. Another short article that kind of talks about a lot of what I spoke about here. You could click on that, and then I think that I've gone over, but I'm ready to. I'll take any questions. I'll entertain any questions that anybody has right now. Okay, so the first question I have: can you explain the desire to move from competence to competency? Sure. Competence is when we determine that somebody's competent, they're essentially safe to enter the field and provide care. Competency is the skills and knowledge that you acquire over a period of time from client interactions that make you as you move from an apprentice to journeyman to a master clinician. So you're building a greater competency over a period of time. If you go to a cardiac surgeon and you're going to have a cardiac bypass, do you go to the guy that has done it 100 times, or do you go to the guy that's done it 1,000 times? And the guy that's done it 1,000 times, what are his outcomes? How are his success? So we can identify those providers. There's a lady that I know. She's a licensed clinical social worker. She's absolutely one of the best. She's got like 25 years in the field, and her capabilities and her knowledge, have evolved over a period of time. But she told me that when she first entered the profession, she was working in Los Angeles at the county hospital, and she said she was absolutely dreadful. And she went home every day and she cried because, this is what she really wanted to do, but she didn't think she was good at it. So, she had taken her certifying exam, she had passed all the tests, she had passed her in-house training, and she had that competence, but she built this competency over a period of time that, really made her that much of a better provider. I hope that answered your question, Alexis.
Danny, you want to talk a little bit on what's kind of the latest state of play, because it's been a while since we looked at it, on integration of 988 and 911. Is there much out there on that?
There's actually a greater push for interaction. As a matter of fact, Kate Elkins, who is at NHTSA EMS, and she's like the 911 guru for NHTSA EMS. She's actually making a big push for a conference in February that she's going to push out to really kind of discuss and work out the 911 988 interface. A lot of times, what we're seeing is in a lot of parts of the United States, there's no capability to shift the Annie-Alley or the patient information over from 911 to 988 or 988 over to 911. And you might say, like, that's not a big deal. Well, when you're trying to find somebody that's in crisis, knowing where they are is really, really important. And, having the callback information. And so people are kind of building these ad hoc systems amongst themselves. Plus, the other side of the coin is the screening. The 988 people are dynamite at helping people that are in crisis and parsing through their problems. But now, if they have somebody that's a diabetic, that might be a little bit harder lift for them. and then getting that information, providing the appropriate call screening and then getting it over to 911 might be uneven at best. And conversely, on the 911 side, identifying patients in crisis, some locales that have that have been doing this for a long period of time, and I'll say like San Francisco, Boston is another one. They do a better job. They're not perfect, nobody is, but they probably do a better job than other communities that that don't have that same level of experience.
Okay. So this is the point, folks, when we can start putting questions into the chat. And so as we're waiting for those to come in, I just want to kind of expand on that in terms of the 988 kind of landscape. A lot of these were pre-existing, right, crisis hotlines. And so as you talked about the anti-alley, but the technological sophistication of a 911 center versus a crisis hotline are usually vastly different. And so so there is a lot there in terms of how they're going to be more closely integrated, which was clearly envisioned with the formation of 988, but that was a kind of a national, high level vision that wasn't necessarily tied into the reality on the ground in a lot of communities, right? It's probably, I guess, tantamount to looking at the adoption of 911 for the first time, and how long it took communities to take on 911, and how dispatching was done pre 911 versus post 911, right? And some of these things are literally it's a multi-line phone, a notepad and a pen, at the low end, right? And so there's a lot there. So it's interesting on the NHTSA or the conference, Dan. Keep us posted on that, and maybe we can send that out.
Yeah, no, absolutely. And Dr. Jennings, it'll be a one-dayer down in DC. So, I mean, if you had the opportunity to take the train down or whatever, I don't know if there's going to be an online option, but it might be something for you to go down, and I'd be happy to make that introduction with you and Kate Elkins. I mean, the funny thing with 988 and 911, I don't know of any non-governmental provider. I don't know of any non-governmental PSAP. Let me put it to you that way. I know that some people have contracted out 911 call screening and dispatch services, but I don't know of a 911 PSAP that's provided by a private provider. You might have better information on that. But on the 988 side, by and large, overwhelmingly, it's these folks that have been doing suicide hotlines and crisis call screening for time immemorial, by and large.
Yeah. And 311 may be of interest there too, just as a potential model, because a lot of communities have kind of figured out the 311, 911 integration. But again, those tend to be public, right? As you said it, there may be out there, but I don't know of any privately run 311 centers either. So,
well, and that's an interesting thing. I never even considered 311 because you see it now. Calls end up, for locales that have 311 services. We see calls that end up at 311 that are eventually 911 calls, and conversely, we see the 911 calls that are really 311 calls. But now, if we enter that into the mix, you could have a client that's having a mental health issue that may end up at 311, and making sure that call gets directed appropriately is key.
Mm-hmm. Okay. I see we've got Paul Maniscalco on on the line. I don't want to put him on the spot if he wants to jump in with anything, but not hearing any questions. I'm just going to ask in terms of the composition of the teams and the kind of capabilities and protective in terms of, you talked about the radio kind of being the minimum equipment to be able to have a direct contact with police if you're going out. There have been a few adverse events where some of these teams have gone out and gotten into trouble. And what are your thoughts on that in terms of the challenges for, in this, I think in those cases, it was 911 dispatchers trying to make those decisions or protocols on assisted behavioral health, response, for the team, or is this a more traditional law enforcement response?
A lot of that is dependent on the locale that we're talking about. So when we speak about places like Los Angeles, for instance, their dispatchers have a lot of experience in this world working through these issues. Los Angeles used to be an NPDS city, and a few years ago, Mark Eckstein, the medical director there, dropped NPDS for their own system, which they felt was better. And so they have the knowledge, skills, and abilities that they've developed over a period of time to sort of figure this out. In other locales, many places are resorting to the NPDS call screening rubric, which has, depending on who you talk to, has varying degrees of success. And some people are extremely happy with it, and some people feel that it's been less than stellar to meet their needs. The reality of this is that as more organizations start to move into this realm and they are standing up, and I think most of the 988 call centers have been stood up, but everyone is still trying to feel their way around the edges in regards to this. And so, you're trying to make the transition now from before that. If you had a behavioral health emergency, you dispatched the radio car and, that was it. You waited for the officer to get on scene, and now if you're not using NPDS, and I don't know if APCO, I know that APCO and PowerPhone, and I can't think of the other one off the top of my head. I know that they have, call screening algorithms. I don't know how good or how bad their behavioral health call screening algorithms are. But the other side of the coin is a lot of communities across the United States, either due to cost or other considerations, don't embrace these call screening tools. Some do, and they leverage them to be very effective. But I think that as you move into this realm, it might be the impetus for these communities to kind of adopt those call screening tools in order to facilitate getting the appropriate resource to the appropriate patient.
Okay. I think based on the questions and the time, and I see a couple people starting to drop out, I think we can wrap things up. Dan, I think it was a great talk, a lot of information. I really appreciate your expertise on this and your kind of global, from the high level down to the nitty gritty. And so thank you for that. When this project gets finalized, we'll certainly communicate that out. And I've got a question here about a certificate. I will address that offline. And with that, I'd like to thank everybody for attending, and thank you, Dan, for your, a great talk.
Oh, not to worry. Thank you very much. Oh, let me hit stop sharing here. I'm sorry.
Okay. And we'll be back in probably in February. We'll start the series up again. So everybody have good and safe holidays and Happy New Year, and we'll see you then. So thank you very much.